This topic is managing pain during labor. Pain varies during each stage of labor. You can see in the image the location and the different colors showing the severity of the pain in each stage. In the first stage, pain is in the lower back and radiates to the lower abdomen. In the early second stage, the pain radiates to the thighs and lumbosacral areas. During the late second stage, the pain is in the perineal and rectal areas with pressure. We want to ask the client what their plan for pain management is and then support that plan. There are different pain management options for the laboring client: opioid agonist antagonists, nitrous oxide, epidural anesthesia, pudendal nerve block, and non-pharmacological options. We'll look at each of these more closely in this video. IV opioid agonists and antagonists. These have a mixed action. They are agonists. They stimulate some opioid receptors. And they are antagonists. They block some opioid receptors. So they act on receptors in the CNS, the central nervous system, to reduce the perception of pain during labor. They have a rapid onset and are used to treat moderate to severe pain. Because they cross the placenta, they are avoided if birth is imminent or expected in less than 4 hours, because they can cause newborn respiratory depression. They are normally administered in the latent period during the first stage of labor. With laboring clients, they don't cause a severe respiratory depression in the mother or newborn as other opioids do. And they don't tend to cause as much nausea and vomiting, but the sedation may be more when compared to a pure opioid agonist. Nursing interventions with IV opioid analgesics. Monitor vital signs, watching for respiratory depression, and also the blood pressure to ensure the placenta is being properly perfused and then the fetus is too. Initiate continuous fetal heart monitoring, watching variability. And avoid opioid antagonists for clients with opioid dependency, because the antagonist action may cause opioid withdrawal symptoms in those clients. Initiate fall precautions due to the sedative effects, placing the client at increased risk for falls. Ensure naloxone is available, which is an antagonist for opioids and will reverse their effects, like reversing respiratory depression. And consider administering an antiemetic prior to medication, because the opioids may cause nausea and vomiting. Nitrous oxide, or laughing gas. This is an inhaled anesthetic. It is inhaled just prior and during a contraction. It releases endorphins in the brain to minimize pain. We often think of nitrous oxide used for dental procedures, but with labor the concentration is 50% nitrous oxide and 50% oxygen, whereas in the dental setting it is 70% nitrous oxide and 30% oxygen. It has a rapid onset, and also the effects wear off rapidly in about 1 to 2 minutes. It is client-controlled, and that prevents overdose. The client decides when to hold the mask to the face and inhale. When they get too much, they will be too sedated to bring the mask back to their face to intake more, preventing overdose. It is safe during any stage of labor, early, active, or second stage. And it does not limit mobility, but we need to be cautious. Our nursing interventions will address this. It has minimal adverse effects like nausea or dizziness. It does cross the placenta, but seems to have no effect on the fetus. The fetal heart rate remains unaffected. But there are some contraindications. Vitamin B12 deficiency, because it activates vitamin B12. Recent bariatric surgery, because it may cause distension of the bowel, resulting in complications. And pneumothorax or bowel obstruction, because the nitrous oxide will enter into any open air space in the body. and will expand that gas-filled space, leading to an increase in gas volume and then pressure in that space. Another contraindication is maternal inability to hold the mask. Nursing interventions for nitrous oxide. Assess maternal and fetal well-being prior to administration. We need to know what their baselines are and also that they are stable. Ensure the client applies the mask correctly with a tight seal. The tight seal is required for some masks to work properly and release the nitrous oxide. Initiate breathing with the mask in place 30 seconds prior to the contraction onset to ensure it reaches therapeutic level for the peak of the contraction. The client should not be left alone because this inhalant places the client at an increased risk for falls. While the effects are short-lived, the nurse should remain with the client to determine if the client is able to ambulate between contractions, which is often the case. Labor epidural analgesia. Local anesthetic like lidocaine along with an opioid like morphine are injected into the epidural space. You can see this in the image along with the levels of analgesia associated with the different levels of the spine. An epidural may be one injection or a catheter may be inserted for continued dosing of medication. It numbs the area below the level of insertion. The goal is to provide pain relief during labor. And while this may be achieved, it may not remove all sensations of pressure. It does require time to achieve pain relief, about 20 to 30 minutes. It can limit mobility because the client will have decreased movement and sensation in the lower body. And numbness may persist 4 to 6 hours after discontinuation, but feeling and movement normally start to return in about 2 hours. Labor epidural anesthesia adverse effects. Hypotension. Due to peripheral vasodilation, this hypotension can cause a decrease in cardiac output and potentially decrease perfusion via the placenta to the fetus. This can be anticipated and should be avoided with a fluid bolus and positioning. Pruritus or itching. This can depend upon what medications were administered via the epidural, but an antihistamine may be prescribed to treat this. Headache, referred to as a spinal headache. If the dura is punctured during placement, the client may experience a headache while sitting up, but then it will resolve when they lie down. Postpartum femoral neuropathy, as seen in the image here. For a client with decreased sensation to their lower extremities due to epidural anesthesia, prolonged hip hyperflexion in the lithotomy position may occur without noticing that the femoral nerve is compressed under the inguinal ligament, and this may cause ischemia of that nerve, which results in impaired hip flexion, causing problems with walking, impaired knee extension, diminished patellar reflex, and diminished sensation on the thigh. Labor epidural anesthesia nursing interventions. Monitor vital signs before, during, and after the procedure, monitoring for hypotension. Ensure consent is obtained and perform a pre-procedure timeout, which are both done for any procedure. Perform continuous fetal monitoring to ensure that any hypotension has not negatively affected the fetus. And position the client for the procedure. The client can be side-lying, or the preferred position is sitting upright on the edge of the bed with the back rounded and pushed back to increase intravertebral space. If the client does become hypotensive, assist them into the left lateral position to increase the amount of blood flowing back to the heart and then to the fetus. Administer an IV fluid bolus if prescribed to increase blood volume. And vasopressin may be prescribed to act against the vasodilation of the epidural. After placing the epidural, the client is either placed in a side lying position or with one hip bumped up or elevated slightly to relieve pressure off of the vena cava to prevent decreased venous return. Pudendal nerve block. Local anesthetic, like lidocaine, is injected into the pudendal nerves, which innervate the lower vagina, perineum, and vulva. You can see this demonstrated in the image. This is administered late during the second stage of labor, just before birth. It can also be used for the use of a vacuum or low forceps for delivery and an episiotomy repair. This relieves perineal pain, but not pain during contractions. We want to ensure that the client understands the procedure and do all the regular maternal and newborn assessments after delivery. Non-pharmacological pain management. Counterpressure. This is applying pressure to the client's sacrum area while having a contraction, and it may help with alleviating back pain. This can be done with the heel of the hand, a fist, or a tennis ball can be used. Hip squeezes, pressure applied to both hips. Hydrotherapy. The client can take a warm bath or shower, which can help with relaxation. Position changes. This is dependent upon the client. Some may be more comfortable in a side-lying position, some in a rocking chair, in the shower, or others on a birthing ball. Ambulation. Some clients find relief in walking. This is suggested for a client for whom the fetal head is engaged. But if the membranes are ruptured and the presenting part is not engaged, the client should remain in bed to avoid umbilical cord prolapse. Application of hot or cold compresses. Warm compresses to the back and perineal area, and maybe a cool washcloth to the forehead may be refreshing. Breathing techniques increase the pain threshold and can be used as a form of distraction and will help with oxygenation of the mother and the fetus. Many clients will learn some different breathing techniques during their pregnancy. We can ask what techniques they learned and then utilize them. We can use meditation or distraction like conversation, television or music, touch or massage, and visualization, having the mother visualize the baby descending through the birth canal.